Good evening, everyone. It's Dr. Towfigh, your host every week on HerniaTalk Live. I'm your hernia and laparoscopic surgery specialist. Many of you are joining me on Facebook Live at Dr. Towfigh. There's also a live Zoom. You can figure out how to find me on Twitter and Instagram at HerniaTalk. And then at the end of this session, I'll make sure that this episode and all the other episodes, we're almost up to 80 now, will be available to you to watch and share on YouTube. So today's guest is a lovely, lovely surgeon. I like to talk with surgeons of my generation, but this is like the newer generation. They're all into robotics and very, very talented. And this is Dr. Alisa Coker. She is a robotic surgery specialist and highly well-trained and assistant professor of surgery at Johns Hopkins Medical Center. You may have heard of it, top university and top medical center in Baltimore, Maryland. You can follow her at Alisa May on Twitter and say thank you and hello and welcome to Dr. Coker.
Hello, everybody. I want to say thank you for having me. Like, it's such an honor. Dr. Towfigh flatters me too much. I do feel like I'm well trained. I've been very lucky to have a lot of people ahead of me that taught me well. And I want to say, like, I am just so flattered to be here. When I was in training, Dr. Towfigh was basically, the female hernia specialist. So even as a resident, I was always hearing your name.
That's lovely.
And you were just kind of groundbreaking. So it's
Thanks.
nice to have a role model. Before you even knew you were my role model.
You know who is my role model is Dr. Parviz Ahmed. Did you ever meet him?
Mm-mm.
He's retired.
Not personally, yeah.
He's retired, but he is just, he was partners with Dr. Irving Lichtenstein, so the whole Lichtenstein hernia repair.
Yeah.
He's behind,
heard of it.
Yeah, exactly. He's behind a lot of what we know about chronic pain, triple neurectomy. He helped invent like the composites meshes. All the composite meshes we currently have are based on his research, and very prolific writer, and he's local. What I didn't know is he's local. And when I was a resident, I would read all these papers by him. And then I went to my first American Hernia Society meeting, and I met all these people whose papers I'd read,
Yeah.
And then he was one of them. And I was like, wait, you're in Los Angeles? I didn't know that. And so I really looked up to him because there's a lot of interest in hernia surgery as a specialty nowadays. As hernia society's grown, et cetera, but there really wasn't back then. There was like a very small group, and they kind of did their own thing and kept to themselves, and it wasn't so mainstream, where SAGES and all these American College of Surgeons and all these societies that are huge now have a big, big hernia component to them.
Yeah, it took a while, but I think hernias have become sexy.
Yes. Yes.
It used to be the thing that no one really wanted to study, or everyone's like, anyone can do a hernia. Well, it turns out not everyone can do a hernia well. Right. And probably it's best left to the people who are trained to do so, right?
And when you were in residency training, did you like hernias, or how did you get involved in the whole, including, because it's a big part of what you do. It's not all of what you do.
Oh, yeah.
But it's a big part of what you do.
Yeah, I mean, I love my practice. It's nice to have some variety. I probably do about a third bariatric or weight loss surgery. And then the rest is pretty equally split between foregut or anti-reflux surgery, and then hernias, the rest. And that's hernias, all comers, open incisional hernias, inguinal hernias, and I do them in all methods too. Open surgery, obviously I'm a big proponent, and I love using the robot, but I do a lot of different applications to fix them. But in residency, I don't remember having a huge love for them right away necessarily. But, I think a lot of surgeons are influenced by the people they work with, who kind of take them under their wings. And I did my residency at the University of California, San Diego, with Garth Jacobson.
Where I went to
Southern California representing.
Yes.
And he is a big hernia surgeon. I know you know him as well. And I enjoyed working with him, and I enjoyed learning his trade really. That's what it felt like. It felt like a specialized craft. And it was just really fun to learn with him. And I knew that I wanted to be in that area of what we call minimally invasive surgery, the surgeons that specialize in the small, doing surgery through small incisions. And kind of, maybe it doesn't make sense right away but they've become the hernia specialists for the most part. So my fellowship in minimally invasive surgery was really an apprenticeship model where I spent half the year doing foregut, anti-reflux, bariatric, and the other half of the year hanging out with Dr. Jacobson, learning hernias.
Yeah, I hated hernias when I was a resident. Absolutely hated it. But because I didn't understand it, and it wasn't until my first year as my first job where I went to the American Hernia Society meeting, I was like, oh, that's kind of cool. Like the stuff they're talking about is way different level than what I ever considered hernias. And then like the rest is kind of history. It's become all that I do.
I see it with the residents at Hopkins. Hopkins is kind of known for big surgeries, a lot of hepatobiliary, so pancreas, and liver cancers, and transplant. And so, when I say, kind of jokingly that hernias have become sexy, it's because those kind of things are, when you're a young budding surgeon, you're like, I want to be a, superhero and do really cool surgeries and save lives. Right. And hernia doesn't have that appeal right off the bat, right? You're not, I still kind of joke sometimes after I fix even a small hernia, I'm like saving lives, and I'm not really saving a life, but what you learn to take satisfaction in is that you are really improving lives, right? Like you see these people who have debilitating pain and are really just so frustrated with their hernia. And so the ability to make their life better, turns out that actually does feel pretty good.
Yeah, I totally agree. It's definitely, I also do the joke saving lives when my trauma colleagues, friends ask me, how you doing? I'm like, saving lives. Because my life saving is really quality of life. I'm improving quality of life, usually. Okay, so today's topic is mostly on robotic surgery. I know you do a lot of that. You're passionate about it. So I listened to your talks on it. We have a lot of questions about it. And the ones that were submitted ahead of time, I already put these up on the screen so we can go through them. And then as people chime in, I may kind of veer to some of the live questions, but maybe you can start with just a very simple question to be answered. Is robotics the same as laparoscopic surgery? When you talk to your patients, do you use the terms interchangeably? Or do you feel that robotics is really an evolution of laparoscopic surgery because there's more degrees of freedom and precision? How do you view it? And then how do you talk to your patients about it?
We're diving right in. Yeah. So I think it's important, one, to know, anyone speaking on anything has their bias, and I am totally biased. I love robotic surgery. I really enjoy doing it, and I do find that I give my patients really excellent outcomes with it, which is kind of the most important thing. So some people might answer this question differently, but what I explain robotic surgery as to my patients, and I don't use them interchangeably. Some surgeries I do think can still be performed very well laparoscopic, and so I will tell patients that I recommend a minimally invasive approach, which really is the umbrella that covers robotic and laparoscopic surgery, or an open approach. And so then once I say, minimally invasive in my hands, often that means I'm going to offer you a robotic approach. I feel like over the years it's changing, that more and more people do actually kind of understand what that is, but there's a lot of people that really have no idea what to expect. And I think the biggest fear is that it's literally a robot, like, artificial intelligence that's doing the operation. One, right. I have no interest in that. I actually like operating and I want to do it and be in control. But it's not like that at all. So the way I describe it to patients is in both laparoscopic and robotic surgery, you have small incisions and you essentially have straws that will be going into your body through those small incisions. With laparoscopic surgery, I'm going to be standing there holding those instruments that are going through the straws. Mm-hmm. And with robotic surgery, the robot is standing over you, essentially holding the instruments. And then I'm sitting in the corner, moving the robot like a crane operator. So I'm in complete control, and the robot is just mimicking my movements. I do feel it is kind of the evolution of that. There are certainly excellent, laparoscopic surgeons who I do think can provide some of the same outcomes as a robotic surgery, but I think the robot makes it kind of more even playing field for most people to get that excellent outcome, and in a way that's not quite as taxing on my body. So that's the biggest difference I notice.
Yes.
So yeah.
Yeah, I like that crane analogy. I should steal that. That's a really good one, because the way I always say is, well, I'm moving, but it's hard for them to understand. But I think crane, that's a really good one. We have a lot of technical questions about the robot, so we're going to keep moving on. So,
but of the people who do love the robot, I will say that's I kind of use the joke, that like if open surgery is surgery, 1.0, then laparoscopic is 2.0 and robotic is 3.0. So.
Oh, these are all excellent. All of these. Talk about the depth perception that is so advanced with robotics compared to all the other options.
So with the robot, there is essentially two eyes, right? So two different cameras we're seeing through. And when you sit down at the robotic console, it's an immersive experience, really. So I just kind of am sitting there and I'm looking through this, goggle type thing. And what's happening is the image that I'm seeing is the combination of those two. And so you essentially get a 3D view by combining it. And you can only see it at that console. So even people in the room, if they're watching one of the screens that has a view of the surgery, they can only see one eye. So for example, sometimes one eye might get dirty, like one of the cameras, and I'll say, hey, can you clean the camera? And my assistant's looking at me like, you're crazy, it's perfectly clean. Like, why are you being so nitpicky? Which admittedly I am. But in that case, I'm like, no, it's like you're looking at my left eye and it's my right eye that's filthy. So the difference sitting at the console is really amazing.
Yeah, the people in the OR, I was like, can we take a look? Because they heard that the visualization is so different. They look, oh, that's so cool. I can't say it's 3D per se, but definitely you have some depth perception that is much, much more advanced than like a typical, even like a 4K monitor. So all our surgery centers and hospitals now have 4K screens for laparoscopy, but the robotic view is still very different. So what are the specific contraindications for robotic surgery? Do they differ from those of laparoscopic surgery, or do you treat them the same?
Good questions. So reasons why I wouldn't offer someone robotic surgery are not very different than laparoscopic surgery. I mean, first off, in order to do either of those minimally invasive approaches, assuming, we're going into the abdomen, the patient's abdomen essentially has to be blown up like a balloon. So we use a gas to create space. So that space is required so we can put those instruments in there. And so some people might have, lung conditions, for example, that mean that they won't be able to tolerate that as well. And so they may not be a good candidate. And then, of course, there are reasons why you might choose neither of those approaches. They're, based off patient characteristics, hernia characteristics, that I would think that they'd have a better outcome with an open surgery.
Right.
And then, there are specific, I would say more than anything, there's reasons I might choose the robot, right? So maybe someone who's had a prostatectomy and radiation and they have an inguinal hernia, you might offer them an open approach, but if you were going to offer them a minimally invasive approach, I'd probably be more likely to go with the robot in that situation, because I do feel like I have better visualization and better control and precision when you're dealing in that reoperative field where there's potentially, scar tissue that's more difficult to deal with. And then I will say, I think what's been surprising to me as a surgeon, in general, surgeons, at least it used to be, it's easier to operate on a thinner, smaller body habitus. just because there's less subcutaneous tissues to go through, especially with open surgery. You know, you're not dealing with a big, deep open wound. But with robotic surgery, it's one of the few situations where if someone is too skinny, I'll actually say, no, I'm going to do you laparoscopic. And it's because those robotic instruments are so long that I feel like you need extra room. So there are some patients that I say, no, I can't get as much distance as I want, and we're going to have to do this laparoscopic.
Yeah, I totally agree. There's, what do you think of the trocar sizes? Lap versus robotic?
I mean, it depends on what you're comparing, obviously, because different surgeries require different trocar sizes, or essentially the straws that we're talking about that we put into patients. There are definitely, I feel like, more when it comes to hernia, there's probably more situations where with the robot, you are trading in order to use the robot a slightly bigger trocar size. So like you can do the average laparoscopic hernia repair with a lot of 5 millimeter trocars, so like little 0.5 centimeter incisions. And then the robotic trocars tend to be 8. But it's such a minor difference that I don't think you see much difference, you know, from the patient standpoint. For example, we don't even routinely close trocars that small because they're very low risk for hernia formation. And in my experience, you know, there's a rare difference. I mean, maybe it's different where you practice with all the beautiful people of LA, but for the most part, most of my patients are not concerned with, you know, an incision that's this much longer. What about you?
No, I have dropped down in a certain subpopulation, these like models / actresses, where I use the 3 millimeter pediatric trocars for the inguinal hernias. Because
it's a different patient population. And you know what? I can't blame them. That's their money maker, right? You know, and I think it highlights though the importance of choosing the right operation and the right tools for the right patient. Right?
Which I think is important I think one thing that hernia specialists like you and I can offer is we don't do everything just one way or just how we learned residency, for example. It's open, laparoscopic, robotic, smaller incisions, bigger incisions, where you place the incisions, mesh, not mesh. There's all these different options out there that to be able to offer you the whole, like, you can like tailor it. I like the word tailoring because I do feel that not one size fits all. I think women are different than men in the way that they recover from some of our hernia operations and the type of repairs they would need and benefit from. Larger people, you know, different repair than smaller people.
Totally agree.
Yeah, so I think being able to offer all those different options is a big deal. This is an interesting question. I have a lot of a very insightful audience. I made none of these up, by the way. These were all submitted. So even though they sound highly technical, they're all from viewers of HerniaTalk. Have you ever faced malfunctions of the robot, such as unwanted movements?
I can't say that I have. I know that's always the fear. I mean, if anything that I have ever seen that could have gone wrong with a robot, like maybe a collision between the arms externally, because there's a lot of arms, it's all honestly human error. And these are all things that are controllable. You know, it's like anything in surgery when people say, you know, I do like anti-reflux procedures and different hernia repairs, and they say, well, would you get this done? And I say, yes, but I would choose the surgeon. You know, and I think it comes down to proper training and knowing that you're in good hands. So like me, I'm neurotic about how I set the robot up. It's just anything else. It's proper setup and knowing your instrument, right? It's ultimately an instrument. Like, yeah, you can cause a lot of damage. It's a very powerful tool. And so I think if anything, it just highlights the importance of specialty training, right? Like no surgeon should be using that tool without being very comfortable with it. And it's one of the reasons I'm passionate about teaching.
True, there's a lot of safety layers too, right? There's a lot of points on the robot console and on the machine itself where you can kind of just stop everything and disconnect everything and prevent any damage in case there's some weird malfunction.
Right. And if anything does happen, what will happen? And actually, I take that back. The only malfunction I've ever seen now is when it thought there was a malfunction and it just kind of froze up, and we literally, like any computer, restarted it and it worked perfectly. But that's what happens, is it stops, right? So it's not that it goes crazy like what was that old show, with the robot? It's not like that. Yeah, it's not like that. It's that it would just stop working.
Yeah, there was a documentary that highlighted malfunctions in the robot and injury from the robot, and there were some early on in the stages, and I feel that it happened before the general surgeons really picked up robotics. It was early on, mostly gynecology that got involved, and there was this lack of understanding of how powerful those arms are if you can't see them, if you're like flailing around and possibly injuring bowel and so on, which again is much of it is human induced error. Then there were complications with like perforations and so on, and that made the news a lot. So there is a little bit of backlash against robots based on those stories and so on. But maybe you can expand a little bit about education, because the company has done an excellent job, probably better than most other companies that have introduced technology, in getting surgeons educated and certified. Yeah.
I mean, one, they essentially require it, that any surgeon who starts using the robot takes a course with them. And that was all supervised. I can't give you all the details of it, but essentially it was required for them to get FDA clearance. And so they have to have a very structured program. It's actually a 2-day program, and get essentially tested to make sure they understand the basics of the tool. And of course, that's just the bare minimum. They also have a lot of procedural specific courses. So for example, I teach multiple hernia courses for them. So people who either are just getting started with a robot, or maybe they're already comfortable doing robotic surgery in other areas, but they want to learn that specific trade. So it's really a nice benefit. And I think, any responsible surgeon takes advantage of these things. I mean, I do. I still look for opportunities to learn new things where I can, and learn from incredible peers. So I was doing, probably the last thing I started doing robotic was my bariatrics. It was kind of like my last laparoscopic holdout. And when I decided I wanted to start doing robotic bariatrics, even though I already felt very comfortable with the robot and I felt very comfortable doing bariatric surgery, it's like, why would I not take advantage of the opportunity? And I took a course on robotic bariatric surgery.
Yeah, so there's an online course where you have to learn about safety, how the robot works, take exams online. You can't even go the next step until you read all that and then take the online exam. And then there's games that you play that are more technical in nature, like video games that are robot based. I love that part. That was like my favorite part. I would go to the hospital early morning before they use the robots and just play those games. And then you take your 2-day course, and then you have to pass their hands-on exam for safety, and then your hands-on exam to actually manipulate, and you have to score a certain level before you can get your certificate. Then you have to go to your hospital and get proctored to do 5 to 10 cases, right? Before you're allowed to operate independently. And depending on your needs and skills level, the company is very generous in flying out surgeons, if there's none locally, to physically be there in the room with you, to answer questions, lead you through the process, make sure that you're doing operations with some input from an expert. So
the hospitals have gotten really involved in the last few years too. Kind of the new, frontier of safety is in hospitals actually having robotic credentialing, where, and that goes down to what you're saying, where they're basically saying, no, you can't use our robot unless you have a certain number of proctored cases. And usually even a ongoing, recredentialing process. So they're looking to say, hey, if you did less than, 10 cases last year, you're going to have to recertify, prove you still know how to do this. And I think that's the safe way to adopt such a powerful technology.
Right, absolutely. It's pretty strict. And our hospital is a Catalyst program, so it's one of many in the nation. So teams come in to the hospital and review like how the nurses run the system, how the scrub techs function, the whole use of like the surgeon, the scrub tech, the nurse, circulating nurse, the schedule, whatever. And they take that information, go back to their hospital and develop a good robotics program. So I must say they did a really, really good job as a company to assure patient safety.
I'd agree.
Yeah. I just have to say that because every time I talk about robotics, there's someone that will say that like robotics is unsafe or should never be done. Or there's concern like, I'm really scared because my surgeon wants to do this robotically. And in many cases, there's more safety and education done for robotic surgery than there is for open or laparoscopic.
Yeah.
It's a good thing. Question about reduction, regrowth, and de novo adhesions. How does robotic surgery compare to open and laparoscopic surgery?
Wow, I feel like that's a high level question.
Isn't it? I think these are so good.
So the reason one of the reasons that a lot of us are proponents of minimally invasive surgery, either laparoscopic or robotic, is because there have been good studies, early on in laparoscopic surgery that show it actually produces less of an inflammatory response.
Right.
And we presume that translates to less likely to form these big adhesions or scar tissue within the abdomen, which can be a problem, particularly, maybe down the road. So you have a great surgery and, 10 years from now, you have a bowel obstruction because of some scar tissue.
Right.
So I don't know that we have any great studies to definitively prove that robotic surgery causes anything less than laparoscopic surgery. I can tell you robotic surgery done well, I think does create less trauma to the abdominal wall, which translates to less pain.
Yeah.
And I think you can be more precise and in control and with that better visualization as well with a robot. So in theory, you might be able to create less inflammation overall, but I can't say, I'm not going to lie and say that I know that that's a fact. But I definitely think any minimally invasive surgery could have a benefit compared to open surgery. But in the end, it's like anything else. There's also just patient factors. Like, you can do the same operation in one person. If you had to go back in, it looks like a bomb of scar tissue went off, and then the other person looks like no one's ever been there before. So there's some variables that you just can't control.
Yeah, some people are just scar formers much more than others. One of the comments made live is, for me, thinking robotics, I'm thinking that robotics is a must if I need surgery because I have a lot of adhesions. But just to be clear though, for the patients that are watching, not all hernia repairs can be done laparoscopic or robotic. Some of them have to be done open. Let's say it's an open mesh repair and you need to remove that open mesh. You have to go back in open. You can't laparoscopically or robotically remove a mesh that was placed like on top of the muscle, as an example.
Yeah.
Right. Yeah. So
yeah, not everything is amenable to a robotic repair. I definitely see patients who come a little disappointed because they look me up and they're coming to me because they want a robotic surgery, and I have to say that I want to give you the best repair possible, and sometimes for some patients that's an open surgery.
Yeah, that's so true. So true. Okay, I think we answered some of these. How many ports and of which diameter are commonly used in robotic hernia surgery? Was it 8 millimeter? How do you identify a safe camera port site if there are adhesions and or mesh? And do you always avoid mesh areas for port placement, even if the surgery is for mesh removal?
Yeah. Well, I think one
Very
of the
specific question.
I know these people have done their research. So one, the question to how many ports, I don't think we addressed that. Typically it would be, you're gonna have at least 3 and sometimes 4. And occasionally someone might choose to put another one for a, what we call an assist port. So the robot's not using it, but you have a bedside assistant that's, putting an instrument in through it, or maybe passing your mesh in through it. So most of my hernia repairs, and the reason it makes sense, right? You need 3 because you have one arm for your eyes, right? And then one for each arm. So you have a right and a left arm in there. Identifying a safe, I would say this is really a question about safe entry, right? For anything. And that's going to be something that's very specific to each patient, and even to the surgeon. When we compare methods for entering the abdomen for minimally invasive surgery, never has there been a study that demonstrates one is safer than the other. The safest method is going to be whatever that surgeon is best at, right? And so how I get in, the residents will sometimes say, like, well, why don't you do it this way? I'm like, well, I do it this way because I've always done it this way and I have really good outcomes doing it, right? So I have no reason to change as long as I'm having great outcomes. But you definitely take into account previous surgeries if there's mesh. So for example, if where I would typically put my ports for, a certain surgery, if I know that someone else has already been there, I think I might encounter a lot of scar tissue, I may purposely go in a separate area where I think I might find more of a virgin field.
Yeah.
Just to assess first.
Yeah, we try not to go through mesh. I get called in every so often for, let's say, urology or gynecology operation or some like cancer operation where the patients had mesh before. And so they kind of want me there to make sure that the mesh repair is not messed up from their operation, because you do have to treat those patients slightly differently. And we're so liberal in placing mesh, sometimes we forget that this patient has a lifetime need of maybe other operations in the future for their colon or for their gallbladder or gynecologic. And so yeah, it's we try not to put our trocars through mesh if possible, but sometimes it's not possible and you just have to do it safely. And there are different techniques with regard to that. So we, one of the live questions was, Dr. Towfigh and HerniaTalk has created a bunch of hernia nerds.
We are hernia nerds.
We love being hernia nerds, first of all. We call ourselves hernia nerds, hernia friends. That's a kind of hashtag that goes around Twitter. But thank you for joining me. She joins us every week, actually. And I love that she does that. And she's very involved with the ACHQC, actually, as a patient. So that's really lovely. So why do you prefer robotic surgery?
I find that I love that immersive field. Yeah. I could give you all the standard stuff. Why do people see a benefit in robotics, right? Yes, it's the precision, it's the wristed instruments compared to laparoscopic surgery, the excellent visualization, the ability to work in really fine, teeny areas that are hard to reach otherwise. So for me, like working, for foregut surgery, and for example, I'm working high up into the chest. Essentially, we're going through the mediastinum, which is a tunnel kind of carving up under the breastbone, and it's a small area. And I feel like I can see better and have better control up there than compared to doing something open. But then also, it's just, when you get passionate about something and you take an interest in it and you do it over and over again and you feel you get good at it and you take pride in that. So that when I sit at the robot, I said, that's my happy place. Like, I know I can accomplish most things because that's how I'm comfortable as a surgeon. If I can get my ports in and I get the robot set up right, then I sit down at that console and I'm, ready to rock and roll. That's how I operate. And it feels good to me. I'm comfortable there. And I say comfortable from that's like a mental thing, but really that translates to a physical thing too. So I'm a big proponent of surgeons taking care of themselves, looking out for themselves. A lot of people, administrators, for example, might only care about the bottom, line, the dollar. signs, and not necessarily a surgeon's comfort. And you could be thinking as a patient, like, well, why do I care if my surgeon's comfortable? But I'd be like, well, you should, right? Do you really want someone to operate on you that they're not focusing on you and they're really just thinking, gosh, like my neck and my shoulders hurt, they're achy, my back feels horrible.
Which is a real
No, you
thing.
want them concentrating on you. And I feel I can do that better robotically. And we know from, all of us know, unfortunately, anecdotally from surgeon friends and seeing it, that laparoscopic surgery puts a lot of strain on your body. Open does as well, obviously, but it's a different type of strain. But laparoscopic in general, I always joke, with minimally invasive surgery, it's almost that we took the discomfort that the patient had with open surgery and we transferred it to the surgeon. And what we've seen, and I've seen it, in my own colleagues, and it's really sad, like young surgeons, under the age of 40 requiring cervical fusions.
Oh my Lord. Yeah.
And not only is that unfortunate for them, but when you look at the cost of that to the healthcare system, that's not good, right? So you have your surgeons that are now non-functional for months while they recover from surgery, and potentially can't continue doing what they were doing before. And when we know that we're facing a huge shortage of surgeons in the future, we need to keep our surgeons operating as long as possible, right? So we need to be comfortable.
Yeah, definitely open surgery is not ergonomic. You can make it so every so often, but you still have to look down often. And that's a big strain on the neck. So the cervical is an issue. Plus you're standing for so long. And that's a horrible strain on lower back. So lumbar and cervical discs and diseases are rampant among us surgeons, and shoulder issues too. But you're right, when laparoscopic first came out, I was like, this is going to be great ergonomically. It'll be so much better because you're not leaning into the patient, but you can't move when you're doing laparoscopic. When you're doing open, you can move around a little bit. You can change the weight that you bear on one leg versus the other. You can move away from the table or move back. Laparoscopic, you can't. You have to plant yourself, right? And that kind of, so you're like with the security guard, the security guard that just stands there and can't move.
Except you're doing a laparoscopic swan dance.
Yes, this is true. That's exactly right. But then robotic surgery, if done correctly, some people don't fix the heights of their monitor and chair correctly, or they use a poorly designed chair. But it isn't very ergonomically correctly designed, where your neck is at 45 and your arms are to your side and you're in lordosis and all that. So yeah, I did have back issues, and my robotic days, I was like, oh, thank God. Because I was going to operate with zero pain. Whereas my lap and open days, oh my God, so painful until eventually that cleared. But it was painful. And I loved my robotic days. Loved it.
I mean, I can tell you, I see the difference in my body now. Now that I've transitioned to almost entirely robotic surgeon, when I can do it robotically, I do. If I have a random day where, for whatever reason, I'm doing some laparoscopic cases, it's funny. This happened probably about a year ago, and it was the next day. I was like, why are my shoulders so sore? And I was like, I'm embarrassed to admit I don't really work out very much. And I was like, I know I wasn't in the gym yesterday. Why do I hurt? And then I realized, I'm like, oh, I was doing lap cases. It was laparoscopic surgery yesterday. So.
Different parts of your body are stressed. Yeah, for sure. Okay, so this is probably the most important question for today, which is, which types of hernias do best with robotic surgery? What's your take on that?
I mean, it's a big question. I think it's going to depend on who you're talking to, surgeon wise, what kind of repairs they can offer, because there's a huge spectrum of hernia repairs that we can offer you. In terms of, how we close the defects, where we put the mesh, how we secure the mesh. And so I think, if you want a basic answer, probably something that's too small in in some patients, it would make sense to have an open surgery.
Yeah.
But again, it's going to depend on the patient. So what I'm looking at is body habitus. So you may have a small hernia, but if you have a large body habitus, I may think that you're very high risk for recurrence. And in order to give you the most durable repair, want to do a robotic approach where I can get a big piece of mesh in there for overlap for you. And then I think where the robot really shines, though, is in surgeries that you would have had to or would have wanted to do open otherwise for a specific technique, like going in what we call a retrorectus position.
Yeah.
So we're able to put the mesh right below the muscle, but in a plane that's still technically outside of your abdomen. And that's one of my favorite hernia surgeries. I think it's a very good surgery, very durable. But that used to require a big open incision, and those patients would be in the hospital anywhere from 3 to 5 days.
Right.
And now, like I said, I think it's where the robot really shines is I can do literally an equivalent repair, but through 3 or 4 small incisions, and the patient goes home the next day. And so I think that's definitely a sweet spot for robotics.
Yeah, I agree. I think that certain operations are just as good lap, especially the ones where you don't need to sew too much, like a typical laparoscopic angle hernia repair. But maybe a really big one, a big scrotal one, maybe you do a better job with the laparoscopy with the robotics, because you can make a wider space easier, you can move further away from it. I think the flank hernias, the side and flank hernias are super perfectly suited for the robotics because you can do a better job of closing that defect and dissecting and seeing those nerves back there. And you're often fighting with a lot of tissue, but with a robot, you have extra arms to help with the retraction. Yeah, I think definitely for flank, I 100% try and do those as much as possible robotic. I must say though, I don't know how it is at your hospital. So we currently do not have robot at the surgery center. It's all in the main hospital. And so during the pandemic, I couldn't do any robotic surgery. Yeah. So I ended up doing many things that I prefer to do robotically. I ended up doing lap. So because I can do it at the surgery center, flank hernia, and then also mesh removal, which I was doing before the robot anyway, but you just get so spoiled when you have the robot.
It sounds painful.
Yeah, but do you guys have a robot in your surgery center?
We don't. It's like the one thing I'm really battling right now. Overall, I think we've made a lot of very positive progress at my hospital, and they're very supportive of the robot. And we actually have a huge fleet. I think we have 16 now across our health system, right?
What? Oh
it's
my
amazing.
God.
We're a big hospital too. Our main hospital has over 1,000 beds and a lot of ORs. So a lot of surgeons use those, but we don't have one in either of our ambulatory surgery centers yet. I'm working on it because I do think that would be a very positive thing to be able to offer the patients that, and especially in, it's a whole other, we should have a whole talk on that, on, the kind of the economics of where hernia surgery is going. And now all these providers that are requiring certain diagnoses like umbilical hernias and inguinal hernias be done in an ambulatory surgery center. And so when I have those certain insurances, I have to tell those patients, I can't offer you a robotic approach because I don't have a robot in our ambulatory surgery center.
Oh my Lord. Yeah. I haven't looked.
So it's an insurance company essentially dictating what, care.
Yeah, we don't like that. We don't like that at all. Wow. So, Gina Adrales was one of our earlier guests on HerniaTalk. She was great. And if I recall, it was shortly after she got recruited to start really the laparoscopic kind of arm of the general surgery at Johns Hopkins, where they acquired, I think 7 or 9, I think 9 robots.
9.
And it's such a huge hospital, but it wasn't really a very minimally invasively known hospital. With Talamini there was, but it was still an uphill struggle. And then Gina, I think Talamini started that culture, and then when Gina came on, it kind of blew open for general surgery, and that's amazing. 17, wow. Yeah, we have a big,
Hopkins had a lot of growing up to do in general. I mean, while we're talking about Gina Dralis is I always say she's my boss. She's like, oh, I'm your coworker. I'm like, she's my boss, but she's also really awesome. And she's one of the reasons I came to Hopkins. But she was, believe it, we didn't have a division of minimally invasive surgery until 2016, which is pretty unusual. And she was selected to be the division chief, and super proud, of her, because she is the first female division chief
in the
at
whole
Hopkins.
system. Oh my God. Yeah, that's crazy. Yeah, it's a very traditional, older system, especially in surgery.
But things are changing. So now I'm happy to say our division, we have multiple hospitals, but directly in our main hospital, my division is basically 3 of us, and we're all female.
Yes, I know that. And I love that. Yeah, I would work for Gina in a heartbeat. She's an amazing leader, just very lovely person to work with, and very strong. Talk to me about large abdominal wall defects. What's the role of robotics, and can you use robotics for abdominal wall reconstruction for the larger defects?
You definitely can. I think you have to, each patient needs to think about what's important to them as well. Is it getting out of the hospital faster and recovery? Is it cosmetics? Because believe it or not, sometimes I have to tell patients, I'm like, the robot, yes, it's smaller incisions, but if you have kind of a big gnarly hernia, maybe a big incisional hernia, and you were left with a big, horrible scar from it, sometimes, if that's what's important to you, everyone's different, but if that's what's important to you, the best thing I can do is give you an open surgery and cut the scar out, right? But what you're trading that for is definitely a longer hospital stay. I think it's pretty amazing to see what surgeons have done with the robot, where they've taken it and how they keep pushing the limits. And so there's a lot of great surgeons out there that are taking on more and more, and they're able to show that you can fix very large defects robotically.
Yeah.
Especially when you combine with other methods, whether you're doing preoperative Botox injections to the muscle to kind of relax everything before you try to pull it together. But I think kind of the sky is the limit. Like when I start thinking about what's kind of we're not going there robotically, it's less to do with the defect itself typically, and more to do with other factors. Like, for example, if someone had like a fistula, like a hole in their bowel that was coming out to their skin, and you're going to have to resect that at the time of doing the hernia repair. Like, that's an open surgery for me all day long. I don't see it ever being robotic, but maybe someone will prove me wrong.
Can you talk about mesh removal? Are all removals done open? Do you do the lap or robotic? How much of that is part of your practice?
I don't have a huge mesh removal practice. Like, I think you being, you and as famous as you are, and getting so many people come to you with their potential complications and wanting your opinion, you probably take out a lot more than I do. But I mean, luckily I'm not, most of my patients do very well, and I don't have to remove their mesh, but occasionally I'll have someone come to me that, the most common reason would be like a low grade kind of chronic infection, and it's just not clearing up. And you just at some point have to say, it's reasonable sometimes to consider trying to clear it with antibiotics and conservative management, but at some point you have to just throw up your hands and say, we just got to get the mesh out of there. It's just like a hip implant or a knee implant. If it gets infected, it may need to come out. Right. And I've taken them out. It depends again on like the hernia characteristics as well. But for the most part, if I can get in there and do it robotically, I will. I've definitely done that. And as you said, it kind of depends on where the mesh is placed as well. So if someone did what's called an onlay and the mesh is directly on top of the fascia, not going to do that robotically. But if it's in a, inside the abdomen, I would rather take that out robotically than open, honestly.
Yeah, the general rule is if the mesh was placed laparoscopically or robotically, then we prefer to take it out the same manner. And in the same vein, if the mesh is placed in an open manner, then we prefer to take it out in an open manner. However, there are exceptions to all of that. And I would like to say that it's complete BS when surgeons that don't know how to do laparoscopic or robotic, and you've heard this before, say, oh, I can do this better open because I can see better, I can feel better, or whatever it is. Complete BS. There's no validity to most of these people that claim that. So there are surgeons out there that will take out laparoscopic mesh via big laparotomy, big open surgery, which makes no sense to me. Just suck it up and refer to a surgeon colleague that can do it laparoscopically and robotically, and don't maim the patient, give them a more risk for hernias and complications and nerve injuries and whatever, and have us do it laparoscopically or robotically. But yeah, you've heard that before, right? Oh, I can do it better because I can see more, or feel more, or something like that.
I mean, it's such like an archaic, stupid argument, honestly. Like, I don't even really waste my time trying to convince those people otherwise. But I think it's important for patients to understand that sometimes, if you see a surgeon and they're not talking about a certain technique, it may just be that they don't do that technique.
Right.
And a good surgeon, will at least tell you that that exists if that's an option for you, and refer you to someone who may be able to offer it to you. Like there's things like with certain surgeries, there's different techniques that I don't perform myself, but I'll tell them, I'm happy to send you to someone who can do that if you want to learn more about it.
Yeah, no, I totally agree with that. And I think that we get this discussion a lot on this HerniaTalk live session, because some patients, I don't know, they're not empowered, or they don't feel like they can see more than one surgeon or ask about more than one surgeon. I mean, even if I need surgery, I would definitely go to get a second opinion and do my own research and learn more, because that one surgeon may just be thinking one way, and then the other one may be able to bring me a different viewpoint. So, and I think, as with any specialty, hernia surgery specialists tend to know more, tend to have done more, tend to tailor better. Our outcomes should be better than non-specialists. So, someone wrote something about, I think my last 35-year-old surgeon, or 35-year surgeon, said he can do my repair surgery better open. Now all my nerves are damaged. We're in a system that doesn't want second opinions. I don't know what system doesn't want second opinions. Even a socialist system of medicine, you have the right to get a social second opinion. It's really how much you advocate for your own care.
Yeah, I do a lot of second opinions, and I'm happy to tell people when I disagree, or even when I totally agree. I mean, I'll do it. So like, no. And sometimes it's a surgeon that I know very well, and I'm like, that's an excellent surgeon. Like, I'm happy to operate if you want, or you can stick there, But I agree. I would want to look around a little bit. I always tell my patients, I think it's important to understand that, especially with what we do, which is elective surgery, right? Meaning you don't have to have it done. You're not coming in through the trauma bay with an emergent situation and you've got to rush, and then it's kind of harder to shop around, right? But with what we do, elective surgery, it should be a partnership between the surgeon and the patient, right? Everyone should feel good about what's happening. So I'm not bullying you into any particular method. And that's why sometimes, if anything, I think what my patients would tell you, they would complain about how long my clinic waits are that they come in to see me. But that's because I spend as long as needed pretty much with each patient. And sometimes that's longer than the allotted time slot, and things run over. But I want to make sure that they've heard about the different options and weighed them all, and they feel like that's what they want to do, right? Because I'm not just telling you what to do.
Yeah, one of the comments says traveling to an expert certainly adds another layer of difficulty, which is true, and cost, but it often is necessary for specialty care. Have hernia will travel. Fixed hernia, I would travel too sometimes. I've had to travel sometimes to my patients, but those were very rare. Usually they come to me. But okay, the next are a couple of questions that are more like just wondering, like during incisional and other ventral hernia repairs, are muscles themselves, as opposed to fascia, ever sutured directly to other muscles or directly to the mesh when used? We tend to like to not sew the muscle itself.
Yeah, the fascia is the strong stuff.
Yeah.
But you have to understand it's intimately related to the muscle. So it's covering the muscle. And so we're doing our best to pull the muscles, like especially if you're talking about a midline hernia, I would like to get those muscles close together. But I agree. I try to avoid actually taking bites of the muscle, because then you're just injuring it and potentially causing more pain as well.
Next, in the same line is, I have read that you cannot suture muscle because of the risk of suture pullout. Is this true or a myth?
I mean, I think we kind of answered that, is that in general, you want to secure, for example, suture and mesh to fascia. That's what's strong.
Yeah.
I don't think the muscle just isn't even necessary.
Yeah, and it definitely pulls through. There's no strength in muscle. Do muscles have to be sewn to more substantial structures such as tendons, ligaments, fascia, or cartilage, or can muscle be sewn to another muscle? We tend not to sew muscle to muscle. We tend not to sew muscle. I'll just say that. At least not for any strength purposes. Let's see.
A lot of muscle questions.
A lot of muscle questions.
Was this all from the same person?
It was. If you sew muscle to muscle, does this require special suturing techniques? Yeah, so you try and use suturing techniques that reduce the suture pullout. So it's more like what we call vertical or mattress sutures, than sutures that can kind of cut through like a cheese, like that cheese wire, you know. You don't want that kind of situation. Okay, another question. When does it make sense to remove a plug only, as opposed to a plug and patch robotically? The plug has not migrated, but it's probably causing pain years after a good repair. That's a good question, because usually people have a plug and patch. It's a two-part mesh system, but the patch is fine. It's the plug part that that is a problem. And if you go by the first logic we said, which is if surgery is done open, then removing the mesh from that surgery should also be done open. But now we got a situation where that may be one of the exceptions, right?
Yeah. I mean, I think it depends on the indication for removal. I mean, there are definitely people have mesh removed because they're concerned that that's causing a chronic pain situation. If you're talking about a recurrent hernia, I can tell you my general philosophy. I always say you don't know what you're going to find till you get in there. And I don't go in there with the goal of getting all the mesh out. The mesh is very well ingrained, and if it's not causing any harm, I feel like you can only cause harm by pulling it all up. So if it's in my way, if I feel like it will interrupt the integrity of the repair that I'm doing, that's when I'll take it out.
Yeah.
And I'll say probably more often than not, it's a plug that's causing that, and not a flat piece of mesh, especially, because that's been done open. So you often won't even see the open flat piece of mesh, that was put on the other side of those muscles.
Yes.
But that plug sometimes is very precariously placed and poking out, and there's no way that you can do a good repair without at least carving it down.
Yeah, that's absolutely true. I think the plug is the only, is the main exception that we have. We're almost done, but there's an important question about the robotic iliopubic tract repair, which I was very much asked to answer. So the robotic iliopubic tract repair is nicely termed rIPT. It's a non-mesh repair of the inguinal hernia. And in my practice, in my study, we found that it's best applied to low-risk hernias, so super small hernias and thin patients, where you don't want to use mesh for whatever reason. And the anatomic structures are Cooper's ligament and the transversalis arch. Let's do this last question because I don't want to leave anyone unanswered. Okay, last question. I have a plug and patch repair for my inguinal hernia. I'm now having symptoms from it and prefer to have it removed. Can I have a tissue repair? If so, can it be done robotically? What do you think?
I mean, I think we answered this a little bit. So if you had an open plug and patch repair, you're not going to be able to likely get all that mesh robotically. And so if you really want that mesh out, it would have to be an open surgery. And then certainly, yes, a tissue repair could be an option for you.
Or you may not. So if you want all the mesh removed for whatever reason, if that's indicated, then yeah, probably a mesh, like a flat mesh repair is preferred over a tissue repair. But if you, in my practice, if you agree that you're going to have maybe a 10, 15, 20% recurrence rate with a tissue repair, which we consider high, it's certainly an option. But, you know, in some people, if you just take out the plug, like you said, robotically, and you leave the patch, even though it's a small patch, maybe they won't have a hernia recurrence.
Yeah.
You know, just leave alone and then just have that discussion that you may have a recurrence in the future because it's not really the best repair to just have the patch from the plug and patch system. But
yeah, I think it's definitely a discussion to be had though, because what I would worry about is then you're violating those planes, and that's kind of your best chance to do that repair from there too. So then if it comes back, it's not quite as easy to do.
Yeah, the question is, what is a plug? A plug is like it's a type of mesh. We think it's too much mesh in general, but it's not flat. It looks like a badminton.
It literally is like a little badminton mesh. There's no better way to describe it. And no hernia nerd would ever put a plug in anybody.
No, our nerdiness.
Just say no.
Not allow it. I'll not allow it. Okay, I'm going to finish with a final comment that was just sent in. As a patient, I value transparency for my provider. I love that you both don't let your pride get in the way of getting what is best for your patients, even if that means guiding the patient to another surgeon. It gives me so much respect for you both. So thank you for that comment.
Thank you.
All right, our time is up. Thank you, Alisa. This was fantastic. I really appreciate it.
It was really fun. It went really fast.
It did go fast and we're fun. We had fun and the questions were great, right?
They really were.
Yeah,
I'm surprised at
every week, which I love to do. Yeah. So thank you for your time. I know it's later in the evening than it is for me. So I appreciate that, your time away from family. And thank you everyone for tuning in. This is another Tuesday night at HerniaTalk Live. My name is Dr. Shirin Towfigh. Follow me on Instagram, Twitter, Facebook, and YouTube. And I will see you again next week. We'll do another one of these. And I'm off to a Lakers game.
Yay.
I hope they win, which I'm sure they will. You guys take care. Bye. Thank you.
Bye.